And we're live. Good evening. We would like to welcome everyone to the Adrenal Awareness Month webinar hosted by the American Association of Endocrine Surgeons and in partnership with the National Adrenal Disease Foundation. I'm Dr. Susana Vargas-Pinto. I'm an endocrine surgeon in New Health, Connecticut, and I'm one of tonight's moderators.
Hi, and I'm Dr. Sarah Oltmann, Associate Professor at the University of Texas Southwestern. I'm our other moderator for tonight's webinar. We have assembled an expert panel to answer all of your questions about adrenal disease. Tonight's webinar is being recorded and will be available through the AAES Facebook page as well as the AAES YouTube channel. And we'd like to thank NADF for providing us with frequently asked questions from the membership, along with the Primary Aldosteronism Foundation. We will also be taking live questions from the audience this evening. Please enter your questions into the comments section directly on the Facebook live stream. And please be aware that we will not be answering any personal medical questions or providing any specific medical advice tonight. For those types of questions or requests, please seek advice from your particular doctor and medical team.
We will start by introducing and getting to know our panelists tonight in alphabetical order. We will start with Dr. Jessie Pasternack. Please tell us a little bit about yourself and your background.
Thanks so much. Hi, everyone. My name is Jessie Pasternak. I'm one of the endocrine surgeons in Toronto, Canada. My background is that I basically train mostly in Canada and live in Canada, but I did move to the States for parts of my training, including my fellowship where I lived in San Francisco. I do full complement endocrine surgery, including research and administration and teaching, obviously. And I'm very passionate about endocrine surgery, including thyroid, parathyroid, adrenal, and other endocrine tumors. So thanks so much for having me. I really appreciate being on this, and happy to participate in any way I can.
Thank you, Jessie. We will now have Dr. Heather Wachtel.
Thank you so much for the kind introduction. It's a pleasure to be here and speaking with you tonight. My name is Heather Wachtel. I'm an assistant professor of surgery at the University of Pennsylvania in Philadelphia. I'm a board certified general surgeon with expert training in endocrine surgery. My area of research is in pheochromocytoma and paraganglioma and the genomics of these fascinating tumors. I practice 100% endocrine surgery. And again, my focus is on adrenal. I'm very excited to be here with you for this incredible event. So thank you to our moderators and to the association for putting together this panel and inviting me to participate.
Thank you, Heather. We will now have Dr. Tracy Wang.
Hi, good evening, everybody. My name is Tracy Wang. As the other two panelists who've already introduced themselves, I'm an endocrine surgeon. I'm really pleased to be here tonight to talk with everybody. I am currently at the Medical College of Wisconsin in Milwaukee, Wisconsin, where I've been since 2007. And prior to that, I did my fellowship training at Yale University in Connecticut. So again, looking forward to the conversation tonight.
Thank you, Tracy. And finally, but not least important, Dr. William Young, our endocrinologist for tonight.
Right, so I'm the one non-endocrine surgeon. I'm an endocrinologist at Mayo Clinic in Rochester, Minnesota. I'm past chair of our division here, and I'm past president of the major academic organization for endocrinologists. It's called the Endocrine Society. My career focus has been adrenal and pituitary disorders. Written a lot about it, think a lot about it. I'm a full-time clinician and see patients every day with adrenal disorders. Happy to be here.
Thank you so much to all of our panelists for joining us this evening. We will now start answering your questions. As a reminder, we will not be able to answer any personal medical questions or provide specific medical advice for your situation. during our very first question, can have them or adrenal pathology?
Sarah, can you repeat that? I think you broke up a little bit.
Oh, sorry. We said we would start with your approach to a new adrenal patient, more from a broad sense, incidentaloma perhaps, rather than focusing on any one disease right off the bat.
And I didn't catch, who was that question for at the beginning?
We'll let all of you take a stab at it. We can start with Dr. Pasternak.
Well, I'm never the first on alphabetical order. It's kind of funny. So thanks so much. I mean, from an adrenal perspective, we have an adrenal incidentaloма clinic actually at UHN. So we have a lot of patients that are found to have an adrenal mass from doing imaging that's not necessarily related to their adrenal gland at all. And so we basically will see those patients now often remotely, and we'll do a biochemical and ensure that biochemical workup prior to and ensure that they have their imaging. My personal biochemical workup, and I'm sure it changed. I'm sure many people have many different workups, but my personal biochemical workup or screening workup is to do a plasma metanephrines to rule out a pheochromocytoma, and to do a 24-hour urine cortisol to rule out Cushing's or subclinical Cushing's. And then I will usually do a aldosterone to renin ratio, which is done usually in the morning, and making sure that people are taking or off certain medications if they have any hypertension. And then I'll make sure they have a CT scan that we can review, and we'll decide based on those things whether there's any further testing or any other interventions that are needed.
Yeah, I think similar to Jesse, I think we're going to go by first names here if I'm not mistaken. Similar to Jesse, I think many of us work with our endocrinologists pretty closely in these multidisciplinary clinics, particularly related around patients who might have an adrenal tumor found, when they're having imaging for something else, which can be a little frightening sometimes to hear that you have something else that you're not expecting to find. And so, we really want to make sure that patients understand what that means and what that might mean for maybe some of the other medical issues they're facing, high blood pressure or diabetes, that type of thing. So, we work with our endocrinologists to work to see these patients and make sure that they have the workup they need, but that they also have the follow-up they need, whether it be with an endocrinologist or their primary care physician. If there is something that doesn't need any surgical intervention or endocrinological intervention at the moment, that they're getting appropriate follow-up for it.
I certainly defer to Dr. Young as he is our endocrinologist on the call, but agreeing with what both Tracy and Jesse have said so far, I think sometimes there's a role for pursuing, sort of alternative testing of cortisol, and we do tend to, at our center, to stick by the guidelines, which suggest that we need two separate tests of hypercortisolism to get a diagnosis of Cushing's. But I think that unlike a targeted workup, which is done for somebody who has clinical symptoms or a suspicion, the adrenal incidentaloma tends to be a challenge because we frequently, as Tracy mentioned, have people who are undergoing, extensive evaluation for other disorders, and we want to make sure that we're seeing the whole of the patient and treating them appropriately.
Jesse outlined the general approach very well. We recently completed an epidemiologic study in Olmsted County. 7% of all people who get either CT or MRI scan of the abdomen will have an incidentally discovered adrenal nodule. 95% of them, it's benign. In other words, not cancer. But then the question is, as Jesse outlined, is whether it's functioning or not. And if it's functioning, could it be contributing to any medical problem for the patient. And that's looking at aldosterone if the person has high blood pressure or low potassium. And if it's something we call a lipid pore, that's a type of nodule that you see on CT or MRI. If it's lipid pore, it might be something called a pheochromocytoma, which is a very rare tumor. And we have a good biochemical test for that. If it's lipid rich, we don't need to test for pheochromocytoma. And the last thing, as Heather just mentioned, is looking to see if it's making cortisol autonomously. When it's making a lot of cortisol, the patient has Cushing syndrome, which is pretty easy for us to see just by doing a physical exam. But what's more common is something we call subclinical Cushing syndrome, where the adrenal nodule is making cortisol day and night, same amount, every minute, every hour, 24 hours a day. And that can lead to other signs and symptoms. And there's a series of tests that we do to figure out if a patient has subclinical Cushing syndrome.
Thank you very much. This is one of the questions from our Facebook page. This is for Dr. Young. In regards to diagnosing for primary hyperaldosteronism, when is it appropriate to screen patients with hypertension for this? And how can the patients understand a little bit what their labs are telling them regarding the diagnosis?
This is a great question. It's very topical. So primary aldosteronism is where one or both the adrenal glands produce autonomously. When we use the word autonomous, we mean automatic, not under normal controls, when they autonomously produce aldosterone. And when that happens, it typically would cause high blood pressure, and sometimes, not always, causes low potassium. It's the most common cause of reversible hypertension. 5 to 10% of all people with high blood pressure have this disorder. 20% of all people with high blood pressure that are on 3 drugs with suboptimal blood pressure control, that's called resistant hypertension, 20% of them have this disorder. The problem at least in the United States, is that clinicians don't think about this disorder very often when they're seeing a patient with what appears to be garden variety hypertension. Whereas it's so common, the question was, how often should we be testing for it? My personal approach is I test everyone with hypertension for this disorder. The problem is aldosterone is toxic to the heart, it's toxic to the kidneys. And I see too many patients that have had hypertension for 10, 20 years, and now they have heart disease and kidney disease. It's not reversible. So we can prevent further damage by diagnosing the aldosterone problem at that point, but some damage has already been done. I'd rather make the diagnosis in the first year of high blood pressure. In terms of the labs, it's very simple to screen for primary aldosteronism. As Jesse mentioned, it's a morning blood test. We measure 2 things, that's all, just 2 things, aldosterone and renin. If aldosterone, in the United States, we use nanogram per deciliter. If aldosterone's above 10 nanogram per deciliter, and if plasma renin activity is below 1 nanogram per ml per hour, many of us would consider that a positive case detection test. That doesn't prove a patient has primary aldosteronism, but it's highly suspicious. At that point, typically the patient should be referred to an endocrinologist for additional tests, which are called confirmatory tests.
Following up to that question, there's another question regarding which medications might interfere with the aldosterone and renin testing.
So this is a pet peeve of mine. I think one of the reasons that so many doctors don't test for this disorder is they're worried about the medications the patient's taking. And the fact is, if a patient has an aldosterone problem, almost no medication is going to interfere with the evaluation. So I advocate that doctors should test for this disorder regardless of the medication the patient's taking. Don't stop any medication. Now, that's a little different than what's in the current Endocrine Society guidelines. It's a very practical approach and it works. So I don't stop medicines to test for primary aldosteronism.
We have one more question for Dr. Young, staying on the primary hyperaldo track. Is there any implication for high renin levels after surgery?
Right. So when the adrenal's making too much aldosterone before surgery, aldosterone's high and it suppresses renin. After surgery, we want to see the aldosterone low. And what happens very slowly is renin slowly rises. And that may take weeks or months to slowly rise, but it will rise. That's the body's normal response once you've cured the excess aldosterone problem.
Thank you very much. And for Dr. Wang, or Tracy, sorry, with regards to surgical decision-making, what additional assessments do you require before determining if a patient's a good operative candidate or not?
So if we're speaking about primary aldosteronism, after the initial workup that Dr. Young went through, as he mentioned, it can come from either your right or left adrenal gland or both adrenal glands. And the management of that can be a little bit different. Currently, I think most people would say that if it's coming from both adrenal glands, we don't typically or ever really perform bilateral adrenalectomy for that reason. And there are some good medications that patients can be on to help manage their hypertension. And if they have low potassium levels, they're low potassium. In order to figure out, though, if it's coming from both adrenal glands or just one, and then which one it is, there is a procedure called adrenal venous sampling, which allows us to determine which gland it might be coming from. The reason we would get this is because abdominal imaging, like let's say on your CT scan, you had a nodule and that's what led to all of this workup. On CT imaging, you can have nodules that are not necessarily the ones that are overproducing the aldosterone. So we never want to get in a situation where we're taking out the incorrect adrenal gland. So I would generally do adrenal venous sampling. There are certain patients that we would say you may not, and again, different surgeons and different endocrinologists have different practice patterns. There are certain patients, younger patients in their 30s, 35, 40s, a rough cutoff. If they do have an adrenal nodule in their imaging and they didn't have hypertension for a long time, those are patients you might consider not doing adrenal venous sampling on because the likelihood of it being, essential hypertension is low. Generally, myself and my partners at our institution, we do have a habit of getting adrenal venous sampling, but that's a critical part of the workup for someone with primary aldosteronism.
I guess as a follow-up to that, and we can direct this to Heather, will you ever proceed with AVS if confirmatory testing is inconclusive? That's another one out of the chat.
Yeah, I think this is an excellent and a very sophisticated question. I think it's one that would really be taken on a case-by-case basis. As a general rule, in terms of an approach, we tend to favor non-invasive testing prior to pursuing an invasive test. So for instance, if a confirmatory test is inconclusive, our general practice at our institution is either to repeat that confirmatory test or to pursue a different type of confirmatory testing, because those are going to be less invasive than putting someone through a procedure like adrenal vein sampling even though adrenal vein sampling is generally very, very safe and very well tolerated. But I think that this is, an unusual case, and one that would really be something that was a discussion between a patient and a care team, and would have to be decided on a case-by-case basis.
I just want to make a point about adrenal venous sampling. I think it's something that, a lot of patients ask me about very often, patients that are not even involved in my care, and they send me emails about this across Canada. And, I do have some experience with the US, but most of my experience is in Canada, and there are some data on this issue as well. But the variability of adrenal venous sampling is quite high in many centers. And I think that's really important to know when you find a care team that you are going to be going and using for your care, wherever they are. It's really important to know about their experience with adrenal venous sampling, because it is a highly specific and very specialized test. And if it's done incorrectly, or if it's done potentially in a low volume center where they're not using the evidence-based methods of making sure that things are done correctly. And Dr. Young is obviously a world leader on this as well. Maybe I'd be interested to hear his thoughts as well. But it's really important to know that there is a lot of quality, the quality improvement and the quality metrics of your center are high, because if it's not done correctly, then it can really influence your care in a negative way, potentially not suggesting surgery for people that need surgery, and potentially suggesting surgery that people don't actually need it. So I think that's something that really important, that I think is something to think about if you do have primary aldosteronism and you're seeking care from a center.
Thank you. As a follow-up to that question, there's another question in terms of adrenal venous sampling. Is it now standard to perform it while the patient is on eplerenone? Dr. Pasternak?
Maybe I can defer to Dr. Young. I think he's published a lot in this, and I'll leave it to him.
Thanks, Jesse. So it comes down to understanding how eplerenone or spironolactone or any drug, how could it interfere with the adrenal vein sampling results? The only way it could interfere, eplerenone and spironolactone block the receptor for aldosterone. So it doesn't let aldosterone work. So I explain it to patients, here's aldosterone circulating in the blood. It has no action by itself. It has to lock into a receptor. When it locks into the receptor, that's what causes its action at the kidney to save sodium, get rid of potassium, raise blood pressure. So what eplerenone and spironolactone do is they throw a blanket over the receptor. So aldosterone's still there. It doesn't change the level of aldosterone, but aldosterone can't get into the receptor because there's a blanket over it. So the question is, how well blocked are the aldosterone receptors, and is aldosterone still working? So the very simple way to answer this question, whether a patient's on spironolactone or eplerenone can have adrenal vein sampling, is you measure renin. If renin is low, that means there's still enough aldosterone around, still enough receptors that it's being active. It's causing sodium reabsorption, increased blood pressure, low renin. So the only time spironolactone or eplerenone would potentially interfere with adrenal vein sampling is when renin is high. And by high, we'd mean greater than 2 or 3 nanogram per ml per hour in that particular type of assay. It's called plasma reactivity. But if plasma reactivity is below those cutoffs, we routinely do adrenal vein sampling at Mayo Clinic in patients on spironolactone and eplerenone. And we're not the only group that does this. Several groups have published on this, showing that these drugs don't interfere if renin is low.
Just to break in here, though, I think that this is a really excellent point and a subtle one, and actually underscores what Jesse said, which is that if you're going to go this route of super specialized procedures, you really want to go to a center that knows what it's doing. And, clearly the expertise, for instance, at Mayo is very different from a center where they do one or two of these procedures, annually. So it's very important to know what type of a specialized center is going and to get care at places where this is a routine procedure and not the first one anyone's done in 10 years.
Thank you very much. So just trying to keep an eye on the clock, we're going to go ahead and transition to theo and paraganglioma. And so Dr. Wachtel, while you're up, if we can direct the first question for you about the testing for theo. Let's start with just what are the medications that may interfere with your interpretation of the labs, and what degree of elevation, regardless of medications, really should be considered diagnostic?
Great. Well, this is an area which is my primary area of interest. So delighted to talk about this all night. We'd run out of time, but very briefly, usually our first screening test is going to be a plasma metanephrin test. And so this is a specialized test, but it's not a fasting blood work. It's something that is a very straightforward test to get. And this is a very sensitive test, meaning that it's very likely to pick up something that's truly positive. But the flip side of that is that it can be falsely elevated. So there are a lot of different medications, and there are actually a lot of different things, even just about handling the blood sample, that could cause this to be false positive. And so we frequently see that the second component, the normetanephrine component of this, can be high. And when it's just a little bit high, so less than 3 times the upper limit of normal, this is actually not diagnostic of a pheochromocytoma or a paraganglioma, simply because there are lots and lots of things that can cause a slight elevation. So generally speaking, we would consider something that is normal to be normal, something that's more than 3 times the upper limit of normal to be very suspicious for a pheochromocytoma or paraganglioma, and something in between to be indeterminate, and similar to the concept that Dr. Young introduced earlier, which is confirmatory testing. That would typically be followed up by additional confirmatory testing, which might be additional blood testing, but most likely to be additional urine testing with a 24-hour urine collection. So in terms of those evaluations, we start with the blood test and then we go on from there. And many people who are undergoing these tests actually have already had an imaging study.
Thank you so much. Also from our feed, there is a question asking if pheochromocytomas are all inherited and when is genetic counseling indicated. Dr. Wang?
Thank you. So pheochromocytomas, paragangliomas are not all inherited, but we do have a high suspicion that there could be a genetic component of them. And, for most, and there's a number of different mutations that can be causing pheochromocytomas. Generally, the consensus right now is if you are diagnosed with a pheochromocytoma, that you speak to a genetic counselor and they obtain a thorough family history and consider and talk with you about getting tested for one of these syndromes. Again, it doesn't mean that you're going to have one, and it's going to depend on everyone's family history a little bit, the likelihood that test will show something, but it is recommended that you at least speak to a genetic counselor to discuss the possibility of that.
Thank you.
And then Jesse, can you talk a little bit about our pheo patients after surgery, whether or not genetics plays into it? Is there any difference in the follow-up or surveillance of these patients based on genetics, bilaterality, size, pathology?
That's a really good question. I mean, I think, as Tracy said, probably a third or more of patients with pheochromocytomas have a genetics, some sort of genetic syndrome causing it. And at least in Canada, we have we have a protocol where we have, genetic testing, screening, and then we do some genotyping as well. So I think it's really important to kind of know what your genetic issue is before you start the follow-up process. From our perspective, I mean, I think, you know, we work closely with our endocrine oncologists to manage some sort of a formal follow-up plan. And that involves both sometimes CT scans to review for any recurrence, specifically for patients that have certain types of genetic mutations that have multifocality or high chance of recurrence. And for other patients or same patients, we may do biochemical testing and screening on a regular basis as well. So those are the two specific parts of the screening process. In terms of the timeline, I think that changes for all patients, and specifically if somebody has something like VHL, where you're looking at other types of tumors, then you may do different types of screening processes as well. So I think it really depends on whether there's a specific genetic problem, whether it depends on what kind of pheochromocytoma paraganglioma they had. If they had potentially a malignant pheochromocytoma, then that would change the follow-up as well. So I think it's really dependent on the initial pathology and the genetics, genetic issue. But I think the screening that at least that we do is both cross-sectional imaging, which is CT scan potentially, and biochemistry, which is the screening test we talked about before, which is the plasma nephrins.
Thank you, Jesse. Question for Dr. Young. How do we prepare our patients in terms of things that they need to do before the surgery so the surgery can be done safely?
Right. So for pheochromocytoma, most centers around the world would prepare the patient with something called adrenergic blockade. So what pheochromocytomas make, they make adrenaline, different types of adrenaline, noradrenaline, adrenaline, dopamine. And all of these, it comes back to that receptor issue. There's receptors for noradrenaline, and it locks in there. We think it's important, and we've shown it's important, to block the effects of adrenaline. That same thing with spironolactone and allopurinol for aldosterone. We give a different type of drug. It's called an alpha blocker, so it blocks the alpha receptor. A typical example would be doxazosin, for example. And we increase the dosage of doxazosin, typically starting 7-10 days or more before surgery, so that the blood pressure is low normal for that patient's age. And as we do that, we like the patients to start a high sodium diet so that they're what we call volume expanded. What excess catecholamines do is they constrict the blood vessels and they decrease the blood volume. And when we give them that alpha blockade, the blood vessels get big and we need something to fill the pipes, and that's salt and water. So that's why it's important to be on a high sodium diet and drink plenty of water in preparation. So most patients can go to surgery on just an alpha blocker. It depends on what the blood pressure is doing and what the heart rate's doing. In probably 30 to 40% of patients, we also add something called a beta blocker. And we typically start that 3 to 4 days before surgery. That helps control heart rate, helps control blood pressure. And we have lots of other medicines we can use to prepare patients. It just depends how difficult it is to control the high blood pressure prior to surgery.
Thank you.
Follow-up question for Dr. Wachtel, kind of going back a little bit about the genetics. So what are the implications of a positive genetic test? What other things should we be screening for or looking for based on the genetic results?
Great. So I have very strong feelings about genetic testing with pheochromocytoma and paraganglioma. About 30% of pheochromocytomas are going to be associated with a genetic syndrome, about 40% of paragangliomas, and up to 50% of patients with metastatic disease. So at our center, we routinely test everyone for germline mutations. And obviously by test, I mean refer for genetic counseling. People can always make their own decision. However, it is very important because it has implications not only for the patient's care, but also for their families. And so people who have a positive test, meaning that they have a genetic change which is associated with these tumors, would typically then be referred for cascade testing. So other members of their family who are first blood relations would go for genetic counseling and also for genetic testing, because it could have implications for their health. In terms of the patient themselves, and I think Jesse laid this out very nicely, is it does change actually not just their own personal management around the time of surgery, because it can have implications for us doing additional imaging or us doing a slightly different surgery, particularly in the case of people who have bilateral tumors or tumors in different locations. And then in terms of the follow-up, the surveillance afterward, our center's protocol for just the pheochromocytoma and paraganglioma, regardless of the genetic testing, regardless of the gene implicated, is to perform annual biochemical testing for life, and then augment that with every other year doing a full body. We have a rapid MRI protocol that actually scans from head to toe to look for additional tumors. So we also use the imaging plus biochemistry approach. And again, for people who have, for instance, metastatic disease, that may also, we may alter that and make it even more frequently, but at the very minimum, it's once a year. So genetic testing really essential in terms of management for people who are positive, but also really important for people who are negative, because it may mean that we are able to change their surveillance going forward. And certainly a lot of people get a lot of relief and some comfort from knowing that they have that test result. So can't emphasize enough how important it is.
So one final question on theo before we transition over to Cushing's. This will be actually for Dr. Young. For our theo patients, when should we be worried about hyperglycemia, and conversely after surgery, any issues with hypoglycemia?
Right. So anytime a clinician sees a new patient with a catecholmine secreting tumor, whether a pheochromocytoma, which is in the adrenal gland, or a paraganglioma, which is the same tumor type but outside the adrenal gland, when they're making adrenaline, noradrenaline, that's what those hormones are. We call them counter-regulatory hormones to insulin. So they don't let insulin work very well. And if insulin can't work very well, blood sugar can go up. So pheochromocytoma is a cause of diabetes. If the blood sugar is averaging over 126, that's diabetes. And when it's due to a pheochromocytoma, we call it secondary diabetes. What type of treatment that needs depends on how high the blood sugar is. Sometimes we need to treat those patients with insulin. Usually it doesn't require insulin. What can happen after surgery, all of a sudden you've taken away all that counter-regulatory hormone to insulin. And now insulin works really well and blood sugar can go down within hours after surgery. So all surgeons that are expert in operating pheochromocytomas know that they need to have an IV that's running dextrose. Dextrose is a form of sugar, so that after surgery, the blood sugar does not fall too low.
Thank you. We're now going to transition into Cushing syndrome. So the question is, for patients that are undergoing adrenalectomy for adrenal hypercortisolism, one of the things that patients may encounter after the surgery is that they may become adrenal insufficient. If I can have Dr. Young again, and then maybe Dr. Pasternak after, comment on this. How can we prepare the patient about that discussion from the endocrinologist's perspective and from the surgeon's perspective?
Right. So before surgery, let's say it's a patient with, we call it adrenal dependent Cushing. So the problem's in the adrenal gland. It's a single adrenal gland that's making too much cortisol, typically a benign tumor in one adrenal that's making too much cortisol. And it makes too much cortisol. It feeds back to the pituitary, which normally tells our adrenals to make cortisol, tells the pituitary every day, whoa, too much cortisol, too much cortisol. So the pituitary turns off and eventually goes to sleep. So when you take away that too much cortisol, the pituitary is asleep, and it doesn't tell the remaining adrenal to make cortisol. We all need cortisol to live. So it's critical to explain all this to the patient before surgery. The surgeon will give extra cortisone at the time of the operation, because as soon as they take that adenoma out from the adrenal, cortisol levels go to 0. So by giving extra cortisol at the time of surgery, the evening of surgery, the morning after surgery, and so on, that prevents what we would call adrenal crisis. Typically, the patient would go home from the hospital on a dose of cortisone that's 2 to 3 times higher than what a normal human makes, because that's kind of what they're used to. And it's up to the endocrinologist to advise the patient on how to slowly decrease the morning and afternoon doses of cortisone until they can get down to normal. And then it's a whole nother process that we don't have time for, of how to get the patient totally off cortisone. That's a different story.
Thank you very much. Dr. Wang, I guess for patients who are struggling with subclinical Cushing's, they often have been seeking a diagnosis for several years before they end up in our office. Can you talk a little bit about what decision or what helps you make a decision to operate when we're considering the diagnosis of subclinical Cushing's?
Sure. I don't know if Jesse wanted to say anything about the adrenal insufficiency. If I can just say one other thing too, is I think, you know, what we as surgeons talk about too, you know, a lot of their immediate perioperative care, sometimes we have our endocrinologists, you know, with us in the hospital helping to make decisions around that. But most of us probably also have protocols around giving extra steroids at the time of surgery and a protocol for assessing their recovery after surgery. So for example, you know, we, in conjunction with our endocrinologists, have a protocol where we don't necessarily in all patients, especially those with mild cortisol excess, start everybody on steroids after surgery. But we do test them while they're in the hospital to make sure they don't need it when they go home, and kind of make sure that they have follow-up there. So that protocol for the patients who are on the call, that might differ at your institution, and depending on what you're having surgery for, and how, you know, the degree of excess of your cortisol levels might guide that. So that's something really important to talk to your care team about. With respect to what you were asking about subclinical Cushing's, you know, that is an area where I think there's differing opinions on what that really means to have subclinical Cushing's. Typically what that means is for the testing that we do, whether it's the dexamethasone suppression testing often, or the salivary cortisol levels, your levels are in an indeterminate range, and the units might differ between here and Canada and other places, but you know, it's not necessarily something that we would say, sure, that is a clear-cut sign of cortisol excess. And in patients with that, we then have to assess, do you have other metabolic disorders that might come from cortisol excess, like diabetes, osteopenia or osteoporosis, high blood pressure, other effects that, you know, again, are pretty common in our population, but also may be related to having mild cortisol excess. And so those are the decisions that we have to make around, you know, do we think that you will have a benefit, will get better improvement, control of your diabetes or your blood pressure by offering you a surgery if your cortisol levels are sort of in this indeterminate, or what we call mildly high range. And that's a careful consideration to have, because you know, we don't want to promise patients that it's going to get better from a surgery, and yet we don't know what the sequelae are 10, 15 years down the road if we don't intervene and do something about it. And I say it's a little bit controversial, because I think some of the practice patterns here in the United States might differ than in Europe and other places around the world in patients who have this sort of indeterminate range of cortisol levels.
I was just gonna add one thing. I I really, really love Tracy's literature on this post-op day 1 ACTH stim test, and I think that's really, really like an ideal scenario. We haven't been able to do that, institute that, but I basically teach that. So I teach that every day to my residents and fellows. But I think one of the things I think from a cortisol perspective, or a replacement perspective, one of the things that I find is that a lot of patients have like the expectation of how fast you're going to be able to be weaned off your steroids once you've been placed on, like let's say you've required the steroid according to Dr. Wang's literature, and you need that post-operative replacement because your HPA axis is now blunted. The issue is that a lot of patients need months and months and months, sometimes year or more, of steroid therapy. And that is something that I have long discussions with patients prior to surgery. I think it's real important to talk about that when you're dealing with at least a single glandular hypersecretion. So that's not in those patients that have both adrenals making too much steroid. This is just for the one side. So I think that's really important to know if you're going to have a tumor or a benign tumor or malignant tumor taken out for overproduction of steroids. You have to remember that you may be on this for a long time. The other thing that I'd say is that in the subclinical patients, it's also sometimes difficult because you run into the same problem you run into with the aldosterone situation, where sometimes you don't really know which side is producing too much steroid. So that gives us, and we don't have the same literature on sampling, venous sampling, as we do from the aldosterone patient. So it becomes a little bit complicated as to what kind of surgery to do and whether surgery is going to help patients that have this problem. So really important to kind of have long discussions with your healthcare team about that. And then the last thing I'll say is patients that have both their adrenal glands making too much steroid, either from pituitary source where just couldn't be controlled, or from we operate on a patient with macronodular hyperplasia or bilateral, both adrenals were producing too much steroid. Those patients will be on steroids for the rest of their life and have sometimes it's very difficult to deal with that. And so really having the supports, making sure you have a medical alert bracelet, making sure that you have your family and your friends involved, knowing that you're going to need steroids, and when you're sick you're going to need more steroids. These are really important discussions to have with your healthcare team if this is something that you're dealing with.
Thank you very much. So now we're going to transition into adrenocortical carcinoma. The first question is going to be for Dr. Young. Should we biopsy an adrenal tumor? And if so, when should we do that?
So as most of you know, Mayo Clinic's this huge medical center. We do 60,000 abdominal CT scans every year. How many times do we actually biopsy an adrenal mass? 20. That's all. Usually we can tell everything we need to know by looking at the CT scan. The only reason ever to stick a needle in an adrenal mass is if you're worried about infection, or you're concerned it could be spread of a tumor from somewhere else and it's not obvious to you that that's the case. But even then, that's usually a rare circumstance. So in general, I advise clinicians, unless they have a really good reason, they should not stick a needle into an adrenal mass.
Thank you.
100% concur with that, but also if you are going to stick a needle into an adrenal mass, do the functional evaluation first, because we all have seen those tragedies of somebody sticking an adrenal mass that turns out to be a pheochromocytoma or paraganglioma, and they haven't done the functional evaluation.
Thank you.
I guess picking up from there, talking about the functional workup and the imaging characteristics, Jesse, do you want to talk a little bit more about the expanded hormonal workup that we do when we're concerned about ACC?
I could leave it to Dr. Young, but I think from my perspective, it's really important to know, what you're dealing with, I think, prior to surgery. And what we do is we have a multidisciplinary tumor board, which reviews these both the CT scans as well as biochemical workup, so that we have a really good idea that this is a suspicion for cancer and what the surgical approach is going to be, and if there's any preoperative or postoperative steroid consideration to think about. We specifically in terms of the functional workup, in addition to doing either a 24-hour cortisol or dexamethasone suppression test, we also do a sex hormone workup, and that sometimes is variable depending on what endocrinology is concerned about, or whether the symptoms and signs and symptoms of the patient are. So I think that's really important too. And then we also often do a DHEA sulfate, which is sometimes can be a tumor marker for us. When we take the tumor out, we can follow this after surgery to see if this is elevated if it goes down at the time of surgery and then it comes back up, we may consider that this may be a sign of recurrent or metastatic disease. So I think there are multiple different hormonal workups that we do, but I think it sometimes depends on signs and symptoms. And I think that, at least in Canada, we're very cognizant of the cost of the workup, the preoperative workup. So we make sure it's really targeted.
Thank you. In terms of surgery, when we're concerned for adrenocortical carcinoma, which will be the recommended approach? Open surgery versus laparoscopic surgery? Dr. Wachtel?
So I think I would be very interested to hear everybody else's opinions. I think that this is an area of continuous controversy in the literature. Generally speaking, if you're operating for a known diagnosis of adrenocortical carcinoma, if you have clear vascular invasion or invasion of adjacent organs, I think everyone would favor an open approach. In terms of oncologic predictors, so whether this is a cancer that's going to come back, one of the primary determinants seems to be whether the capsule of the tumor is intact. And I think this gets at the question you asked earlier, should we be biopsying adrenocortical carcinomas? And we think that these tumors have a propensity to seed. So if you violate the capsule, they're much more likely to recur either locally or potentially even distant metastatic disease. And as they're some of the most aggressive of all human tumors, it's obviously in everyone's interests, and particularly in the patient's interest, to have the opportunity for a curative surgery if no tumor at all is spilled. So some of the studies would suggest that a laparoscopic approach, which takes the tumor out whole without violating the capsule, can have very similar outcomes to an open approach, which doesn't violate the capsule. But I think we all, agree that the ability to achieve a cure is of paramount importance, and so excellent oncologic technique would be required. I'd be interested to hear other people's thoughts.
Well, and I was going to transition that actually over to Dr. Wang next to also elaborate a bit more about the extent of surgery when we're worried about ACC. And is there ever a time when surgery is no longer an option?
Yeah, so just to follow up on one thing that that Heather said, I think, I will say this right off the bat, my bias is if I'm really concerned about a primary cancer, I will do an open procedure. However, I have, trusted friends and colleagues and endocrine surgeon who are experts who feel, there are instances where, at least beginning a minimally invasive procedure is appropriate. And I think that gets to, for patients, knowing what your surgeon's experience is. So even if there is a tumor that maybe is not a clear-cut adrenal cancer, and the approach is initially a minimally invasive, that when they begin the procedure and they see the tumor, that they understand when maybe the minimally invasive approach is not optimal, and then have the ability to switch to an open procedure. I think that's a really critical point. And then the other thing I will say is, we talked a little bit about adrenal cancers from other sites. And I think there is a fair amount of literature to say that those tumors are likely safely performed laparoscopically or minimally invasively. So I just want to say that. And then getting to your question, Sarah, sorry. So adrenal cancers, yes, there is a time when, they are not going to be able to be approached surgically. when we talk about procedures, so whether you're doing it laparoscopically or open, there is a debate around the lymph node dissections and where the tumors might spread in the different lymphatic chain. So what areas of lymph nodes should be taken out and if they should be taken out. And Sarah and I have kind of written about this, but there's a lot of debate, because I think, you know, what we know about this disease depends a lot on what people have done, and it depends on what the intent of the operation is. So right now there's a discussion around, is it beneficial to take out lymph nodes? And the answer is, I don't think we really know that answer. We think it's beneficial to take out lymph nodes, but the problem is that a lot of the studies that exist right now, it's hard to know, it's hard to get back into the surgeon's brain when we look at the data and say, did they intend to take out these lymph nodes, or were these lymph nodes just taken out because the tumor looked bad or kind of with the tumor? So the intent of the operation and taking out lymph nodes is where I think a lot of us are not sure what the data ends up showing. I think if you have a primary adrenal cancer and you are doing an operation, you want to be as complete as you can in taking out not just the cancer, but anything that is around the cancer. And so I think we all favor a wider approach in taking out the tumor and some of the tissue that's around it. And depending on whether it's on the right or the left side, knowing where the lymph node drainage might be is probably where I think we all feel we should at least be intentional in looking in those areas, even if we're not removing additional lymph nodes.
Thank you very much. And did any of our other panelists want to weigh in on that particular topic before we wrap up?
I just want to add, I think that Tracy's comments are exactly on point, at least from my practice and my thoughts. And I think one of the things that I see, at least in Canada, a lot of people will see a surgeon or a surgical team or a non-surgical team and say, these people say 100% needs to be an open operation. And as many of you know, we don't biopsy these tumors, so sometimes you don't know if it is an adrenal cancer. It may be a lipid poor adenoma, and it doesn't have any concerning features, but somebody has decided, or a radiologist has decided, this is a cancer and it needs to come out, and then the team decides that if it's a cancer, it needs to come out open. So I think there is a lot of there's a lot of nuance to deciding, how to, and I totally agree with what's been said. Like, if you have a concerning tumor that is invasive, locally advanced, definitely an open operation. In fact, sometimes we should sometimes give, we sometimes give in our center, we sometimes give preoperative chemotherapy to try and see if we can understand the biology of the tumor a bit better, because the biology is, as everyone knows who does a cancer surgery, biology is really the key to the outcome. And so I think there's a lot of nuance to understanding whether there's what the surgical approach is, whether there's a perioperative optimization or some sort of a chemotherapy option even before surgery or after surgery, and other types of targeted therapies. So I think really important to kind of have a team that understands these ideas as exactly what Tracy was saying.
Thank you. As we approach the top of the hour, we would like to thank our viewers and our supporters for joining us this evening. A special thank you to our expert panelists for taking out of their busy schedules their time, and for answering our questions and discussing this extensive topic, which is adrenal disease. We want to thank again the National Adrenal Diseases Foundation for their support.
And as a reminder, this session was recorded and will be available on the AAES Facebook page and on the AAES YouTube channel. For more helpful information for patients, be sure to visit our AAES patient education website at www.collectedmed.com/AAES patient education. And that will also be posted in our Facebook live stream. Thank you again for your participation.